All right, good evening. What we're talking about today is something which is very important for all surgeons to know about because bile duct injuries are a source of big time morbidity. Okay, and so the best thing is to avoid it. And if you can't avoid it, at least you must know what needs to be done when you do indeed face a bile duct injury. I have an interesting story to tell you. I had a very senior surgeon who was 20, 25 years senior to me, who had been, it was pre-laparoscopy days, and he was a very good surgeon. And we were talking about bile duct injuries, and I had had my first laparoscopic bile duct injury. My 35th lap collie ended up with a bile duct injury. And I used to discuss my cases with him, and he said he had been operating for 25 years, done hundreds and hundreds of open cholecystectomy, and hadn't had a single bile duct injury. And he was a very, very honest and transparent person, and I'm sure it was true. And as luck or ill luck would have it for him, he calls me 2 weeks later and said, I wish I hadn't claimed that with you, Lakshman, because he had his first bile duct injury at open surgery, after 25 years of doing gallbladders. The reason I gave the story was to tell you that, it can happen to anybody, anytime, happen to anybody, anytime. And it is important for us to be humble and to understand our vulnerability and the vulnerability of the patient who has to undergo the difficulties of a damage like that, and be ready, equip ourselves to deal with it if that unfortunate event occurs. Now, why is it important? Cholecystectomy is one of the commonest general surgical operations. It's also well known that there are a lot of variations in the extrahepatic biliary tree, which makes reading the anatomy, identifying the anatomical structures, a bit of a challenge. It's a challenge for very senior surgeons, experienced surgeons, and a much bigger challenge for youngsters. And as I said, it can lead to a significant morbidity. And so we're going to look at all these aspects of the biliary tree, and how you recognize a damage, what do you do when you have a damage, and that is the substance of this evening's discussion. So the first thing you need to understand is, what are the kind of variations that one can come across, and what is the kind of incidence of this variation? Samir, you want to have a go at it?
Hello?
Yeah, go on. What do you think is the incidence of anatomical variations in the extrahepatic biliary tree, and what are those main kinds of variations? If you don't know, say you don't know. I'll ask somebody else.
No, sir.
You have not read up about it. It's good to come, read up about it and come when you come to a class like this. Nikita.
Sir, the most common ones are cystic duct anomalies or aberrations, sir. Like short cystic duct or the insertion being at a different point than the usual.
Good.
Probably entering the hepatic duct, sir.
Yeah.
And
or low down on the bile duct.
Yes, sir.
Yeah. Okay.
And right hepatic ductal system being different.
Okay.
Which is coming in the way over the Callot's triangle, sir.
Right.
And even the aberrations of cystic artery
Right.
can also be confusing the whole anatomy, sir.
Sure. Yeah. But what do you think is the incidence?
So incidence probably around from the literature what I have read is around 30 to 40%, sir.
It's already on the screen. Most often quoted is 15 to 20%, but some even quote 50%. I agree. It can be very high. So these are the pictures here tell you what the kind of variations are. This very low insertion. Are you seeing my pointer? Are you guys seeing my pointer on the screen?
Yes, sir. Yes, sir. Seen, sir.
So this very low insertion is one of the dangerous things. And you can have it coming in front of the CBD, as in this case, the cystic duct can go around and get attached to the left side of the common hepatic duct. It can come behind the common hepatic duct and come again attached to the left side. So you can see the variations are very many. And so when you are, and if the bile duct is thin, it can be sometimes as thin as as a cystic duct. It need be no bigger, 3 millimeters, 4 millimeters. You have CHD and CBD, which is only 3 millimeters. Okay. So when you have that, it's very easy to confuse that for a CBD for a cystic duct. And also, when you have pathology, stones in the Hartmann's pouch, things like Merizes, and forget about Merizes, even stones in the Hartmann's pouch, impacted stones, and added inflammation and fibrosis. If the inflammation is of a few days duration, you can understand how easy it is to confuse the anatomy in the callous triangle, the cystic duct, CBD, and the CHD. The description here is not to scare us. It's not meant to scare youngsters or surgeons, but to be aware that you have to be very, very careful and have an open mind. Even though you have done hundreds of gallbladders, one should have an open mind, be aware of this anatomical variation. Okay, so why do you think the bile duct gets damaged, Praveen?
Sir, due to this anatomical variations, sir,
A little
it can
louder,
be due
please.
to. Hello, sir.
Yeah, go on.
Yes, iatrogenically, it may be due to misidentification of anatomy, sir.
Right. One is
CBD is
iatrogenic, the other is traumatic. Okay.
Yes,
I'm
sir.
not talking only about surgery. Even though it's commonest to have it during surgery, it can be otherwise. So it's traumatic or iatrogenic. That's the basic classification. So what kind of
Yes, sir.
traumatic injuries can you get for the bile duct?
Traumatic, penetrating injuries, sir.
Yeah, could be blunt or penetrating trauma,
Sir.
but extrahepatic biliary damage in blunt trauma is very unusual. Sometimes when you have major, it's always accompanied by major hepatic injuries. It's isolated blunt trauma damaging the extrahepatic biliary. It is almost unknown. It will be a big hepatic injury and associated injuries. Okay, but penetrating injuries can occur and can, a stab injury, for example, even a bullet injury can damage the extrahepatic biliary tree, but always, usually, not always, but almost always, it will be accompanied by some kind of vascular injury as well. But in iatrogenic injuries, what can you get?
During cholecystectomy, that is due to misidentification.
Okay.
And excessive use of cautery near callus triangle.
Okay.
Clips.
But is it only the surgeons who do it, or can other doctors also damage the bile duct?
During ERCP also.
Yes.
Sir,
Yes. And
Uh,
invasive radiology. You're doing
Radiology.
Percutaneous any invasive procedure, or even minimally invasive, like a transhepatic cholangiography. You put a stent and you use a balloon. Even radiologists do it, endoscopists do it, but by and large, it's mostly the surgeons who do it. Very interestingly, go on.
And sometimes the balloon itself can break or get dislodged there, and also the baskets.
Yes.
I had recently one case where the basket was stuck, and it was being done by a senior gastroenterologist. In fact, Dr. Isan mentioned, and he was not able to remove it. He had to leave it there, and I had to explore open and then remove it.
Absolutely. I mean, very true. So radiologists, any kind of procedure on the biliary tree can end up with its damage. That's something we must all be aware of. Very interestingly, I grew up with laparoscopy, 92. Since 92, we've been doing laparoscopy. In the mid 90s, if you looked at the literature, the CBD damage rate was 6 to 8%. Can you imagine? 6 to 8%. That was what the literature said. If you look at papers coming out in the mid 90s, 95, 96, in that time, that's because the trend then was to see what we call cowboy culture. See one, do one and teach one kind of culture. People were not trained in doing laparoscopic surgery. The laparoscopy wave took hold of the whole world, and everybody was sort of having a go at it. And so the CBD damage rate was very, very high. But now, after stabilization with proper training, proper understanding, we are now looking at 0.3 to 0.5 to 0.7% range of CBD damage. It's not zero. That's something we all have to bear in mind. All right. So we understand that it's not only, so even though they are the largest number, it's not only the surgeons who can cause damage to the biliary tree. Enough and more has been said about safe cholecystectomy. I think you've even had recent discussions. I haven't seen those videos myself, but I'll give you my take on this, which is no different from the rest of the world. I think it's important that we identify structures. When when laparoscopy started, Woodwardia, Tempton Woodwardia, who was one of the pioneers of laparoscopy in Bangalore, in India, used to say, hug the gallbladder. Don't bother looking at the cystic duct, bile duct junction. Just look at the junction of the gallbladder with the cystic duct, that's the Hartmann's pouch, cystic duct. And so hug the gallbladder and you're unlikely to damage. And I'm not very sure that that's quite correct. It's important for us to see the bile duct, if not dissect to see the junction of the cystic duct with the bile duct. It is important for us to see the bile duct. And it's almost always possible to see the bile duct. So if you guys, many of you have seen me operate and you've seen me see you through surgeries, I always ask my students, which is, show me the bile duct. As soon as you put a laparoscope in and see the callous area, I tell them, show me the bile duct. So the first thing that I do is look at the bile duct. And if you can't find it easily, look for it. Not with great dissection, never with cautery, but just by shifting tissues and maybe snipping the peritoneum in that area over the bile duct. Check and see where the bile duct is. Once you see that, it's a different ball game when you do the callous dissection. If you can't see the bile duct, then there is some issue. You need to worry about it. Excessive traction is to be avoided. If you pull a lot laterally, you actually convert a straight CBD into a C with a convexity towards the Hartmann's pouch, which means that when you're dissecting in that area, instead of clipping the cystic duct, you can clip the bile duct, or at least a part of it. You can see how, imagine how the whole thing becomes a loop, as it were, instead of having a straight trajectory towards the hilum. We all know about the Ruvier sulcus and the rule that you must keep above it. The yellow arrow shows that. And the critical view of safety, where only two structures must be connecting the gallbladder to the body, to the hilum and the area of the the lesser omentum or the foramen of Winslow, and in that area, only two structures, the cystic duct and the cystic artery. Before you do any clipping or any kind of cautery or any kind of energy source use, see to it that you see this area clearly. And if you stick to these, you'll be fine. And you will see throughout the discussion today, I'll be telling you, get help, get help, get help. If you have any doubt in the anatomy, however senior you are or however junior you are, if you have a doubt in the anatomy, don't proceed. You always have help. You always have people who are out to, ready to help you. Wait, get help, and then proceed with the dissection. There, it is safe for the patient and great learning for you, because the senior will come and clearly clarify the anatomy for you. And if he cannot also make out the anatomy, he will tell you what next safe steps to do. So remember, until you have at least 100 gallbladders under your belt, until you have that, try and get help when you have any doubt about anatomy. Okay, so what are the danger signs which tell you that this is a difficult gallbladder, where you may have problems with dissection, where you may have a potential for damage of CBD? Nitya, let the registrars have a go.
So one thing is when there is extensive adhesions and patient is already in acute cholecystitis,
Yes.
and uh, when we are suppose if we are asking for a bigger clip, then that itself should be a caution that we are we at
Large tubular structures. Yes, correct.
Mm, the danger sign would be if something is pulsating. If we think that if it is cystic artery, but if it is pulsating so much, then we should always keep a thinking cap on it is actually cystic artery or some hepatic artery branch that
Right.
is there. And
Pros and callous, we start with that.
yes,
Okay. If you can't, I showed you the picture in the previous slide where all the tissues were nicely laid out. Many instances, you can't dissect it like that. Everything is stuck. It's fibrosed. You can hardly get planes. You can hardly divide, put your Maryland into safely, and you're always worried that you might either poke into the cystic duct or gallbladder or the bile duct or even the artery. It's a frozen callus, it's fibrosed. So that's the first difficulty, because when that happens, anatomy is distorted and you can't dissect with safety. That's a definite danger sign. As you rightly mentioned, structures which are bigger than what you expect it to be. If you have when you're asking for a large clip, as you nicely put it, are you clipping the CBD is something. Adhesions you already mentioned, and bleeding. See, when you are proceeding smoothly, this is true for all surgery. If you're proceeding smoothly and in the right areas, right planes, it's unlikely that you'll get bleeding. So if you get a lot of oozing, it need not be a pulsatile, projectile bleeding from a cystic artery or a hepatic artery. But even then, if you have a lot of oozing that makes you uncomfortable, where you have to use a suction to even see where you're operating, that is something that must raise your antenna. Then that's a time when you need to ask for help. All right. Now, when you see such a situation, either help is not available, or you think you should, basically help is not available. It's going to take a long time before somebody comes to help you. What are your bailout options?
doing a subtotal cholecystectomy,
Okay.
starting from this first approach and then going ahead with a
Yes.
subtotal cholecystectomy.
Okay.
Or converting it to open so that
Okay.
we get a better dissection, this thing.
Right.
And
Sanya, you want to add anything to it?
Sir, if we have injured something and if there is a bile leak, to keep a
That
drain.
comes later. We are looking
Okay,
at
sir.
bailout, where we will discuss about if we injured something later. But
Okay, sir.
But I'm looking at, you have a difficulty getting the callus dissection going. One of them
Yes,
is
sir.
conversion, one of them is subtotal. Anything else?
So can we just abandon the procedure
abandon.
and
Yes, very
go
good.
to a higher?
Yes,
Yes.
yes. When would you not? No, that's a very good option, but when would you not abandon?
And there's a lot of bleeding which is not
Okay,
not controlled yet.
control bleeding, yes.
And
And
patient condition is
Sepsis
unstable for
patient.
sepsis
patient condition is what? Bad with
Patient is
what?
unstable.
because of
Unstable
the
with what?
gangrenous cholecystitis.
Because of
Sepsis.
Sepsis.
sepsis, you're right. Okay. So when there is active sepsis going, you can't abandon. So I mentioned already get help. So I'll excuse you for not mentioning get help, second opinion. But this is something which is the next step before you do subtotal or convert or whatever. I think it's important that you get an intraoperative cholangiogram. It can be either by putting a little tube into the gallbladder. Your difficulty there would be that if the neck is blocked by a stone, then you won't get a biliary tree. The second thing you can do is try to see if you can see the cystic duct and put a puncture hole, just a needle into it and then inject it. Or you can even inject the CBD. I wouldn't recommend it to youngsters, but experienced people can if you know where the CBD is, you can put a little needle into it, put a dye, and you will get that. Or you can, nowadays you have access to ICG cholangiogram. That is, I have not used it, but it's something that's very, very good. We mentioned subtotal and conversion here, and abandon procedure if the patient is not septic or if is not actively bleeding. Okay, so the picture you see here, Praveen, can you describe this picture here? What have I done here?
You have anterior wall of gallbladder, you have opened it up and tried
Very
it.
good. Very good. Yeah. See, the Hartmann's pouch is in the right lower quadrant of your picture. So cystic duct, callus, gallbladder, bile duct, they're all actually just outside this picture. So I have cut it to the left of the Hartmann's pouch. I open the front of the gallbladder. And then what do I do next in a subtotal cholecystectomy?
We'll do NMOS ligations. Just
En-masse ligation. I do something before I do the ligation. You see something, it's staring at you at the in the picture.
Milk out the stones.
Yes, you can't leave stones behind, okay? Particularly on the patient side or the Hartmann's pouch side or the bile duct side of the gallbladder remnant, you have to scoop out all the stones, wash it out and make sure that that is clear, and then take out the rest of the gallbladder, subtotal cholecystectomy. And what are the next steps? Do you really think you can en masse ligate a thing like this?
We need to dissect the posterior wall of the gallbladder, sir, to
Correct.
maximum possible extent.
Correct. And you're left with a big flower-like opening, which is a remnant of the gallbladder towards the patient. The
Suture
distal
We can
closure,
part,
sir.
suture the
sorry?
closures.
Suture it, sir.
Suture the.
Yeah. Is suture always a must? Have you guys read up about subtotal cholecystectomy? There is a
Fenestrating type,
fenestrating
I
and the
think.
non-fenestrating type.
non-fenestrating.
Okay, so suturing the gallbladder is not a must, even though I usually suture it. It's not a must. People have left it open, and many times the cystic duct is blocked, and so there will be no leakage of bile. But always play safe and leave a drain behind so that if there is a leakage, then you're not ending up with a bilioma. All right, so that is the subtotal cholecystectomy is my first approach because I'm fairly sure that I'm keeping away from the bile duct. But if one is not very sure of it, then it's always good to get an intraoperative cholangiogram before you do a subtotal. All right. And as you all mentioned, abandoning the procedure is a very definite option. So what are the risk factors in now? These are the bailout and anatomy and the difficult situations. Now we're getting into the actual bile duct damage from here onwards. What are the risk factors of a bile duct damage? All right. We have not troubled Inas. Go on, Inas.
So the first was the anatomical factors, like we told, sir, like if there is any
As I
anatomical
keep on
variation.
saying, Inas, as I keep on
Yes, sir.
saying, whenever we ask something like this,
Yes, sir.
classify them, give them
So
big headings, and then you can, if necessary, give subheadings or give the items under each of the headings. So
yes.
go on,
Uh,
give me the headings first. Let me see if you can give me the headings.
The anatomical factors, sir. Then
Okay.
the other could be like related to any aggressive disease, sir.
Related to?
Disease, sir, like acute cholecystitis or which
All
is
right.
leading to a frozen calyx.
Okay.
Then like even associated with the patient, sir, like supposedly if the patient has some underlying disease or he's undergone a major previous like abdominal surgery leading to adhesions,
Good.
sir.
Good.
And so then like operative, like surgeon's technical
So
factors, sir.
if I ask you to first give me the big headings, what would you give? You
So,
said some of them, but it's not complete. First
so
is patient factors,
patient factors, so then like technical errors, sir,
surgeon factors,
and anatomical, sir.
all right, and
Yes, sir.
anatomical factors.
Yes, sir.
All right, so anatomical variations is the first one. Patient factors, lot of adhesions, previous abdominal surgery. It's been shown that it's much more common in people who are obese, in males. If you have cirrhosis and overhanging liver or an extra sized liver, for example, or nodular cirrhosis with nodules coming in the way, acute inflammation, these are all the patient factors. Inexperience and fatigue. This fatigue is something that people have not written a lot about. There are some papers, if you're interested, you can look at the papers, but at your stage, you don't have to look at the paper level. I have read them because of my interest. And it has been shown that if you are working for a long time without getting anatomical clarity, then you have an issue. So I have put a moratorium on myself. I think I'm very, very, conservative. I don't prolong my operation. Within half an hour, if I can't define the callus, an average all gallbladder in our hands takes about 20-25 minutes. But in half an hour, I've not even defined the callus. Then I start thinking about either subtotal or conversion. Okay, you may try for an hour, but definitely it is shown that if you're working for more than an hour, and not defining your anatomy, your judgment definitely gets affected. So I would strongly recommend to all of you, if you do not get your anatomical definition, preferably within half an hour, maybe extend it to 45 minutes or maximum 60 minutes. Do not try to define anatomical structures. Go to your bailout methods. That's the message I would like to give you. Okay. And very, very interestingly, literature suggests that 80% of CBD damage situations occur without risk factors, which actually must must make all of us extra humble and extra, keep our feet on the ground, as they say, put your feet on the ground or head on your shoulders or whatever expression that people use. So normal risk-free situations where you think everything will go fine can end up with a disaster like a CBD damage. And so it's very important for all of us not to take even easy gallbladders casually. You got to be focused until you get the anatomical definition. All right. Niranjan, anything to add so far?
The two other probable factors will be, one is a chronically contracted gallbladder, where
Yes.
it will be small, that is very dangerous, and maybe the difficult dissections in post ERCP cases.
Okay. Yeah.
Other
Sure.
than that, everything else is covered, I think.
All right. Any comments or questions from the registrars and students?
The equipment related also, sir.
Yeah, in the sense,
But
yeah,
yeah.
it's true. I mean, one has to, you're looking at lack of insulation and things like that.
Yes, sir.
Maybe
Yes.
burning something else. Yeah, fair enough. That's also something we should understand. Correct. Yeah.
Sir, how do we
Go on.
so how do we if in bailout options, how are we deciding whether to go ahead with subtotal cholecystectomy or to convert to open, sir? Like when do we do
Whatever you're comfortable with, the surgeon should be comfortable with it. So you'll find that, students of today are not very comfortable with open surgery because you would not have seen any open surgery, right? You will have seen very few open surgeries. So I have a feeling that youngsters they're more confident doing a subtotal cholecystectomy than an open cholecystectomy. Whereas if you call a senior surgeon, for example, he might say, why bother with this subtotal and all that? Let's open up and do it. So it is subjective, but the deciding factor there is the surgeon's experience and surgeon's attitudes. Then you can decide between the two. Yeah. Okay. So when you have a CBD damage, for you to know how to deal with it, you have to, as I keep on saying, classify and put them under baskets, under groups, so that in your mind, you're sure about what you want to do. Okay. So I'm not asking for the actual classification, but what are the principles that are used in classifications? Samir, have you done any reading about classification of bile duct and what are the headings that are used to put them in different groups?
The basic classification is based on anatomy, sir, and
Okay.
also on the mechanism of the injury, whether
Yeah.
it is thermal or just clipping,
Okay.
and also the timing, sir. Like because the atom classification, which was in 2013, they have mentioned this anatomy with timing and mechanism.
Correct. That's generally okay, but these are it. The level of damage, the way you approach this would be dependent on these three factors: level of damage, degree of damage. Is it partially affected, completely affected? What is the etiology? How did it happen? Because depending on whether it's a shearing force or an electrical energy or whatever else, then that is a kind of uh, damage that decides what methods that you use to correct it. Okay. And you'll find that there are so many kinds of classifications. I took this out from the guidelines. You can see There's a Bismuth, a Strasbourg, McMahon, Bergman, Sandis, Stewart and Way, Hanover, Lau, and you mentioned Atom. That's right. It's one of the latest classifications. The most common one used in the literature is Stewart and Way. Strasbourg also is commonly used. Perhaps they're equally used, I think.
I think they
And
call that Stewart and Way is a modification of the Strasbourg.
correct.
Stewart Way modification of Strasbourg classification.
And the higher limit, the E of Strasbourg, is your bismuth. Okay. And so if you look at it this way, Strasbourg, this is a classical Strasbourg classification, and it has A, B, C, D, E, and E is further subclassified, and that is what is the bismuth. Okay. So as you know, they may ask you in the exams about what is what. I don't mug it up, and I don't expect my students to mug it up. What you have to understand is that the Strasbourg is perhaps the commonest. Level E is perhaps the biggest damage that you can have. The A, B, C, D are relatively lower degrees. As you can see, up to A, B, and C, it's only the branches of the cystic duct that is in trouble. A mild problem with the bile duct or the common hepatic duct is D. And when the major problem occurs with the CBD or the CHD, then you have the E level. And in that, distance from the bifurcation. Okay. If it's more than 2 centimeters, less than 2 centimeters, or if it is less than centimeters, is it involving the division itself, the right and left hepatic ducts? E4, for example, even the division is gone. In E3, a part of the lower part of the division is gone, but the upper limit is still holding, the upper wall is still holding. So this is the classification that you have to bear in mind. And when you do an ERCP or an MRCP, you will define the damage. We'll look at that a little later. And then you decide what needs to be done. We will, of course, go into what needs to be done a little later. Now, it's also important for us to understand what are the consequences of a bile duct injury. Okay. We have some guests here. Can we ask them to answer as well? Ganesh Hegde, do you want to have a go at it? What are
Yes,
the
sir.
consequences of a bile duct injury?
Good evening, sir.
Good evening.
Yes, sir. Sir, to guess, I would probably guess depends whether recognized intraoperatively or postoperatively in the ward.
We'll look at it, but what do you think are the consequences? What happens when bile leaks from a damaged extrahepatic biliary duct?
Biliary peritonitis
Yes.
is one complication, sir, and
Yeah.
loss of electrolytes,
Yeah.
like potassium, and sepsis, biliary sepsis.
Yes. Bilioma and sepsis, cholangitis. Anything else?
Nothing else that I can recall. Sir.
See, as I said, if you classify it, you can look at it as immediate or late. The immediate consequences of bilioma, collection of a bile, it's not generalized peritonitis. It is stuck in the right upper quadrant, for example. So you have a bilioma, you have biliary peritonitis. If it's not limited to the right upper quadrant, you can have cholangitis, you can have jaundice, and you have sepsis. Bilioma can be septic. 35% of the bile ducts, particularly in an obstructed biliary tree, are infected. So there can be an infection. Whereas if you look at the long-term things, it can be biliary stricture, recurrent cholangitis, because of stricture and cholangitis, biliary cirrhosis, because of cirrhosis, portal hypertension. If the vascular injury accompanies a biliary injury, you can have liver atrophy, and in an obstructed, inflamed tissue, which can occur, it can even lead to cholangiocarcinoma. A higher incidence of cholangiocarcinoma has been reported in as a long-term consequence of biliary stricture. Okay, these are the consequences of BDI, biliary duct injury, and as you can see, these are not small. There's a lot of morbidity in bile duct injury. Now, as Ganesh was saying, a lot of depends on whether you detect it on the table. Sanya had also started mentioning about it when we discussed it. When you detect this on the table or when you detect it afterwards, right? How you approach it is very different between the two situations. So the first thing you need to know is what are the things that you see when you suspect that possibly the extrahepatic biliary tree is damaged. That is something that you need to know. As a surgeon, as you're doing your gallbladder, there's something amiss. Your antenna must go up. So, Sanya, you want to have a go? What are the things that would make you think that maybe the CBD or the CHD is damaged?
So first of all, a broad structure that Nitya told,
Okay.
if it is a white tubular structure. Second,
Yes.
the color of the bile.
Yes.
If it is a golden yellow bile.
Yes.
And third, if the injury, like Rubius sulcus that we've spoken about, and if we have clipped it or some damage has happened below that,
Yeah.
so we should be thinking more of CBD injury, sir.
Yeah.
And for the hepatic duct, if any bile leak that we see that is happening very close to the liver bed, sir.
Yeah, no, that wouldn't help because cystic duct also can do that. But yes, you said the most important thing. A thin, clear, light yellow bile is from the biliary duct. Whereas you will find that anything from the gallbladder, it can also leak and leaks very, very commonly, Bile and stone spillage from the gallbladder is very common, 10 to 30%, 20% is an average. So this will be darker and thicker because it is stored bile. Whereas what's in the bile duct is fresh bile, it is thin, and it's light yellow and it's clear. And that is the main thing that you have to know. You will find that majority of bile duct injuries are not recognized on table. Only 25 to 40% are. And you can sometimes actually see visualization. What happens is you put traction, you've done something, and then you find that there is some bile leak that you suspect, and then you leave the traction. And then the anatomy becomes a little more clear to the surgeon, and you'll then actually find that you've perhaps damaged the bile duct or the common hepatic duct. That you can see. And the other thing is, I always look at the gallbladder side. After I put a clip and cut, if you see that there must be a single lumen there. If you have sometimes a crumpled, clipped duct can confuse you whether it is single or double lumen. But by and large, you will see that if you look at the cut cystic duct stump, there will be a single lumen. If you suspect there's a double lumen, have a doubly careful look at the rest of the biliary tree. All right, that's something that you have to do. And as I said, your fallback mechanism, if you're still in doubt, is to put a little needle into the bile duct and put a dye, get an on-table cholangiogram. A little puncture wound with a needle does not do any damage. It doesn't cause great biliary leakage. And all you have to do is see where the bile duct is and then put a little needle, a long needle that goes through into the laparoscope. You can aspirate it to see if you get bile first. And once you know that you've got bile, you can put a dye into it and confirm that the biliary tree is intact. Okay, that is the presentation on the table. So we now go on to looking
So then how do we recognize if it is CBD injury or hepatic duct injury, sir?
cholangiogram.
Cholangiogram.
If you
Okay.
cannot, you see, sometimes you can actually see where, once you know that there is something, you can actually cut the peritoneum on the CBD. It needs experience. Honestly, I'm not recommending it to people who are starting off, who've done about 25, 30, 50 gallbladders. You must call somebody who's experienced, who's done hundreds of gallbladders. And you will see that they actually dissect out the peritoneum at the free edge of the lesser omentum. That's on the CBD without using energy, using scissors, pressure to stop the light oozing that you get. And you can actually lay out the CBD as it goes to the hilum. And then you can then even see the right and left hepatic ducts and the CHD. And if you can do it, that's fine. But if you cannot do it, even if the expert cannot do it, then what I resort to is a cholangiogram. I put a needle into the bile duct where I can see it. If I cannot recognize the bile duct at all, I poke and draw. And if I draw blood, I know I'm in the hepatic artery or some other structure. If I draw bile, I know I'm in the bile duct. And then I put a dye in and see what happens. And
So any introp cholangiograms that you have,
that's what
sir?
I'm talking about. That's exactly what
No,
I'm
sir. Do
talking
you have any pictures of that where we can
Pictures.
recognize? Yes.
Pictures, I've done very few of them, to be honest, but
Yes,
I
sir.
can't, I mean, I must look at my collection. I must
Okay,
have
sir.
interologograms. Yeah, I must
Okay,
have.
sir.
The other alternative is that you can take away the clip that you put on the cystic duct stump, and then put a cannula into it and then put a dye in. That's
That,
another
yes.
alternative. That's another alternative. Okay. But
Yes.
getting a cholangiogram is important in these situations. Yeah. Okay. So what are the options when you have an on-table leak? Whom shall we ask? All right, Nikita, have a go at it.
Sir, it depends again on the expertise of the surgeon, sir. Once we
Good.
detect it, if we
Yeah.
are able to manage further, we should confirm the injury point
Yeah. Then what do you do?
and classify it, sir, whether it is what kind of repair it is.
Okay.
Can we directly
What are the
repair it, or
options? You tell me all the options that you have.
sir, if it is a minor injury, we can directly do a repair depending on the expertise. But
Okay.
if you are not well good enough, we'll have to put a drain and refer to the higher center, sir.
Correct. Very good.
No, even if before you do
it's a
that,
major,
what you can do, you can always call for help.
yes,
Introp.
sir. Yes, sir. Yes, sir.
That is a
That
given.
is the
Okay.
first
Please
thing.
understand.
Yes, sir.
Whenever you have a problem, it's a given, not only in bile duct injury, in any operation, anytime. First item, call for help. Okay. I've stressed it already a lot in this. So remember that. Yeah. Go on.
Yes, sir. Yes, sir. And in case if it is a major biliary duct injury, then it might require hepaticojejunostomy, sir.
Okay. All right, you're sort of there, but there must be a little more clarity. So as I keep on saying, get a cholangiogram for clarity of where it is damaged. And the procedure that you do depends on expertise available, level of damage, degree of damage, how much of the bile duct is involved, if any, and the associated vascular injury. So what I'm going to give you is, I hope to give you very clear ideas about what needs to be done. But the situation is very, very complex in the sense there are so many factors which influence your decision. And so the first requirement for that is getting help. Get somebody who has done these, who has seen these before, and then they will help you see you through this difficult situation. Okay. So what are the options when the on-table leak is detected? You have done these, you have looked at these factors which influence the decision. And we then go on to actually what can be done. And to add to what Nikita has said, the simplest thing is don't panic, put a nice big bore drain and refer the patient to a center, or even in your own center, wait until you can get an expert to come and deal with it. That's the simplest and the best option that I'm going to give to a young surgeon. Now you can do a direct repair if you can see the anatomy, where it is damaged. You can, and you know that you, as long as you're sure that you're not narrowing the bile duct, it's a reasonably sized bile duct, you can do a direct repair with or without a T-tube cholangiogram. And if the bile duct is damaged a lot higher up, nearer the hilum or midway between the hilum and the duodenum, the idea is to do a hepaticojejunostomy. If it is low down on the bile duct, it happens when you have dealt with a low insertion of the cystic duct and that has caused the damage to the bile duct. And if you find that it can be, the duodenum can be brought on to the bile duct without too much trouble, you can do a Colli Doco duodenostomy. Okay, these are your options. Any questions or doubts so far? Because these are some things which you need to understand clearly. Yeah.
No doubt, sir.
No doubts. Okay.
Yes.
So, delayed presentation. You have not realized that you have damaged the bile. It has happened. Patient comes back to the ward. How do you recognize that there could be a damage to the bile duct? Praveen, you want to have a go at the things that you would that will make you suspect that there may
Yes,
be a
sir.
bile leak.
If there is a drain, we can see the bile leak, sir.
Yeah, but we
Otherwise,
don't leave a
patient.
drain in normally, do we?
Yes, sir.
Yeah.
No, sir. If there
Yeah.
is, otherwise patient will present with fever,
Okay.
recurrent pain, and obstructive jaundice, deranged LFT.
Okay. Okay, go on.
Abdominal distension.
Yeah. Great tenderness or even guarding. Okay. One of the things that you guys haven't mentioned, which is very, very important, is this breathlessness. Okay. There is, because of the bile leak, because of the infection, because of the irritation of the diaphragm, they really are very, very uncomfortable. My very first case of bile leak, I told you my 35th lap collie. I'll never forget that. I had a high index of suspicion because the patient actually presented with tachypnea and tachycardia. All patients until then, you've seen your gallbladder, hundreds of those even you would have seen. They're happy, having breakfast and smiling the next morning. This lady was unwell. That's all. She was tachycardic and she was breathless. And to such an extent, I wondered if something is happening in the lungs. And so I called my pulmonologist friend in Oakhard, where I had done this case, and he actually went through her and said, "This must be a pulmonary embolism." Okay, and we really felt that that would not be. I have to rule out bile leak, is what I felt, and so I got an ultrasound done, which showed a collection. Okay, it showed a 300 ml collection uh, under the liver, and we did an ultrasound guided aspiration and found frank bile. The point I'm saying is two things you must know. If the patient is slightly unwell, even on day one after gallbladder coli, please have a high index of suspicion. Costs you very little to get an LFT and an ultrasound done. And you'll find that if there is a big collection and if there's a deranged LFT, which almost certainly will not be there before surgery because you would have done that, you would have checked that the LFT is okay before doing your lap poly. If there is a deranged LFT, it may not be a big degree, but a slight degree. Then don't say it's because I handled the bile duct that happened. Okay, don't say it's just handling, or maybe there's a little leak from the gallbladder bed. No, don't play it down. Always have a high index of suspicion. Keep the patient NPO, hydrate them well, give them antibiotics, and watch very, very carefully. Okay, but please do not look for these gross signs of peritonitis because you won't get them. You have to catch them and deal with it before you have those signs, clinical signs. So what are the investigations that you would do? Go on, Inas.
So first, routine blood investigation, CBC and LFT, sir.
What are you looking
Like if there is a picture of cholangitis, sir, then there could be a raised total leukocyte count, sir.
Right.
And so the LFT, like bilirubin, will be
What
deranged,
about the
sir.
other thing about CBC? If you have a low hemoglobin, for example,
So that could bleeding, sir.
yeah, please remember,
Yes,
sometimes
sir.
as we keep on saying, even though we are talking about bile duct injury today, there can be an associated vascular injury as well. Yeah, go on.
Yes, sir. So LFT, apart from that, sir, which will show deranged enzymes and deranged level of bilirubin levels.
Correct.
And after the ultrasound of the
If the enzymes are generally okay, but the gamma GT or alkaline phosphatase is very high, what do you think is happening?
so it could be like a non-obstructive cause, sir.
It is an obstructive cause, young lady,
Oh, sorry.
caused
Yes,
by
sir.
the
Yes.
surgeon. He has not cut
Yes,
off the
sir.
CBD, but has
Oh,
clipped it
yes.
off.
Oh, okay. Yes, sir.
Okay, he has put a clip across the CBD.
Oh, yes.
All right, I must
Yes,
tell
sir.
you the disasters that can happen. This happened in Newcastle, UK. In the early days of lap collie, somebody had clipped off all the structures of the porta. You'd believe it's impossible, but it has happened. CBD, artery, vein, everything was cut off. Okay, and the patient landed with a hepatic transplant afterwards. All right, so you can clip the CBD very easily. you may have a bit of bilirubin raise, but one of the things that characteristically happens is a raise in the alkaline phosphatase and gamma GT, like an obstructive jaundice. Yeah. Okay, go on. So LFT will be deranged. What else? Yeah.
Then, sir, ultrasound can be, get an ultrasound done, sir, to
Okay.
look for any collections, sir, or any bilioma formation like that,
Okay.
sir.
Okay.
And so CT can also be done, sir, like to further delineate the structures and plan management, sir.
All right. We will go into
Mm.
that in a little while because it's important for
Yes,
us to
sir.
understand the role of CT and other investigations here. You haven't mentioned MRI and ERCP. They are also tools that we have to use, and we will look at what role each of these has as we go along. Okay. So the bloods you mentioned, electrolytes, creatinine, always get coagulation studies in addition to liver function tests. It's important when anything happens to the biliary tree. Now, ultrasound is the first thing that we all get, and I still agree with it. I also get it. But very interesting that if you look at the guidelines, some of them, they mention that ultrasound can be done, but they choose CT as the first line of treatment. And I personally haven't found why it should be so, but I think that's because they're concerned that ultrasound, while it tells you that there's a leak or a bilioma, does not delineate the biliary tree anatomy well. And so they straight away recommend CT. All right. And in that, you have to understand it must be a triphasic CECT. Okay. It is arterial, venous, and a delayed phase. Only then you will get the kind of information that you want. You must also have a contrast enhanced MRCP. Whether this should be first line or CT should be first line is a toss-up. But I always feel that an MRCP, after ultrasound, an MRCP gives you probably more information than just a CT. And of course, we have the ERCP. There may be times when after an ultrasound, you may jump straight to the ERCP. What would be the advantage of that, if at all?
Both diagnostic and therapeutic in one setting.
Therapeutic. Yes, sometimes if it's a small damage, partial damage to the bile duct, you may even give the treatment. Therapeutically, you may solve the problem when you do an ERCP. So, depending on the situation, availability, the first line is still ultrasound, and then if you have the availability, you can go for ERCP straight away. Or you want to learn more about it, you can do a triphasic CECT or an MRCP. Okay, radiology, the CT does not actually give you exactly where the damage is. It can sometimes point towards it, but it is less good, less specific than MRCP in that aspect. But you will see free fluid, you will see perihepatic fluid collections, you will see proximal dilatation if there is a clipping of the CBD, as I mentioned. And of course, in other trauma, I'm not talking about post-operative ones, but in blunt abdominal trauma, for example, it will give you a lot of information about liver lacerations and other solid organ injuries. So the real primary indication for me for a CT over an MRCP or an ARCP is a non-operative suspected damage of biliary tree. If you have other organ involvement, for example, pancreas, liver, kidney, in a blunt abdominal injury, definitely go for a CECT first, not ARCP, not MRI. All right. Apart from the ultrasound, of course, you would have done a fast in those situations. But if it is an operative damage, I think you're within your rights to, after the ultrasound, go for ERCP. Or if ERCP is not readily available, you may want either a CECT or an MRI. So please note that a CT can only give you a fluid collection. It cannot tell you whether it is a seroma, hematoma, or a bilioma. And it cannot localize exactly where the biliary, extrahepatic biliary tree is damaged. It can only give you a general kind of information that there is something that is damaged. So these are classic pictures of CTs. I've just taken it from the net, in fact. And this is a kind of a subtle damage where you have fluid collection in the fissure and right here as well. okay, of the liver. It's a very, very mild damage, but nevertheless, there is damage. And that is something that should lead you to the next step, which in this case almost always will be an ARCP. Okay, let me just go with the MRI as well, as we're saying. It's important to understand that CT is a static study, whereas MRI is a dynamic study. All right, so it can actually, you can enhance it by giving this liver specific contrast called the gadotaxate. It, of course, like CT, gives you fluid collections, but it is better than CT in actually telling you where the leakage is from, which means that you can then classify this business. We talked about bismuth classification, 2 centimeters proxima, I mean, less than 2 centimeters from the hepatic, but hepatic confluence, or more than 2 centimeters. You can actually, in an MRI, locate where the leak is from, and that is the advantage of an MRI. All right. We mentioned about ERCP already. It is both therapeutic, it's definitely diagnostic and sometimes therapeutic. But can you tell me where it cannot give you the kind of information you need? Where you think, having done an ERCP, it's useless?
E-type injury, sir.
Sorry?
The E-type
Complete
injury.
transaction.
Complete transaction, or not necessarily transaction?
Complete clipping, sir.
Clipping. Okay. If you're completely clipped off the CBD, you put a catheter from below and diet, and it'll go and stop there. You know that you have clipped, but it gives you no more information about what happens proximally. It doesn't even tell you where the leak is, whether there's a leak or not. Okay. So complete transaction is a problem. Okay. But if you do not have a transaction, I mean, if you do not have even complete transaction, it'll tell you where the leak is. But clipping is a problem. But if you do not have complete clipping, ARCP is very useful. It tells you the presence of the leak and site of the leak, and can be therapeutic if it's a partial damage. If it's a complete transaction, there's nothing you can do. Not even complete. If it's, if more than half of a CBD is damaged, ARCP cannot correct it with a stent. You'll continue to have a big leak. Small leaks, either from the cystic duct or a small hole in the right hepatic duct or these common hepatic duct or bile duct or something like that, can be treated with stenting alone. Okay, these are the investigations that you have to do. Any questions?
Sir, regarding MRCP,
Yeah.
do you advise MRCP preoperatively for some cases that you expect difficulty in drop? Preoperatively, do you advise?
No, but my only indication for MRCP pre-op is altered LFT, where the CBD has not been visualized well by ultrasound. So you have to rule out CBD stones, and so here MRCP is the investigation of choice. If you find is an acute gallbladder, you will find that you may expect difficulty in dissection. Very rare that I ask for an ARCP, but one of the things that young surgeons may want to do is to get an ARCP and put a stent. See, MRCP may tell you the way that the CBD is normal, that there's no stone, but to correlate that with an intraoperative finding is impossible, almost impossible. So when you have a difficult callus, an MRCP picture hanging, on your OT X-ray viewer will not help you. What will help you is a stent in the CBD. Okay, so if you feel that you need some help in terms of delineating the anatomy, pre-op, get an ERCP and a stenting done. That is the way to go, to give you some more confidence when you dissect the callus during surgery.
And especially when you're suspecting Mirizi syndrome, I think so.
Yes,
that is mandatory. Yeah,
absolutely.
Even though LFT might be normal.
Yeah, absolutely. Yeah. Okay, so if you find that, as I said, when there's complete clipping, you cannot get any information proximally, you can't even establish a leak. The way to go about is to get a PTC, percutaneous transhepatic cholangiography, and that will tell you the state of the proximal biliary tree. Okay. Now, at this point, what would be your therapeutic options? Sanya. Are you there?
Yes, sir. Yes, sir.
Yeah. Why are you thinking so much? Go on, say something. Okay, I'll make it simpler for you. You detect this on day 2 of your surgery,
Yes, sir.
okay, or the first post-op day or the second post-op day. What would you do? What would you do if the patient actually gone home and comes back ill and is, 10 or 12 days after your surgery that you do all these investigations and you find a leak? Those are the two scenarios that you can
Yes.
consider. Yeah.
Yes, sir. So immediately after once investigating and we found out that there is a CBD injury. So if at all we have, sir, if the amount of collection there is minimal, we can consider managing it conservatively with
What is a minimal
antibiotics.
collection for you?
So quantity wise,
You are getting into troubled areas there, okay? So
yes,
a
yes,
better index for you is the patient's state,
parameter.
mental state,
Yes, sir.
parameters.
General.
Is
Yes, sir.
tachycardic, tachypnic, running a fever, raised white cell count, even 100 ml is dangerous.
Yes, sir. Yes, sir.
All right.
Yes.
So
Yes.
don't go by the volume of the collection. Look at the
Yes,
general
sir.
condition of the patient. And yeah, okay. So the patient is unwell and he has a substantial collection. What would you do?
Collection. First, we can consider draining that collection, sir.
How?
In the percutaneous drainage by
Okay.
ultrasound guided.
All right.
And if at all the drain, if, once the collection is drained and if the patient condition is improving, and if LFT is coming within coming down with the
Yes.
downward trend of counts and LFT, we can manage still conservatively.
Right.
But if the collection continues to increase or it is the same, and if the patient condition is not improving, we might have to consider other modalities like
Like what?
ERCP or laparoscopic
ERCP and
exploration
stenting.
again.
Okay. Now we'll
Stenting
do
or
it step by step.
yes, sir.
ERCP and stenting. Now,
Stenting, yes, sir.
ERCP and stenting is not possible, or you've done it and the patient is still not better. What do you do?
Yes, sir. Laparoscopic exploration again, sir.
Okay.
Laparoscopic bar open depending on the expertise as well as whatever findings are seen, sir.
Okay.
Initially, go ahead with the diagnostic laparoscopy and see if we can identify where the injury is, what type of injury it is. And once the injury is identified, we can suppose it is a CBD CBD injury, then we can put a T-tube and suture the CBD on that.
Okay.
And if we have
Would you do
transected
it on day 10 or day 12, or would you do it only within in the first few hours, first few days, 1 to 3,
we
1
can
to
do
3
it
days?
at any time, sir.
You should be a little careful about that. Okay. So
Okay.
because your stitches won't hold if it's an old
Yes,
injury.
sir.
Okay. Stitches
Okay.
won't hold if it's an old injury.
Then in such cases, should we consider hepaticojejunostomy?
Not even that. Even their stitches don't hold.
So
There you
Please
have to
remember
wait out till the fibrosis happens.
Niranjan, sorry, say that.
sorry,
Niranjan.
sir.
That is what, in that scenario, you have to wait out till the fibrosis happens and get the tissues get thickened.
Yeah. All
So we
right.
just keep the drain and wait.
So remember, yeah, this is the point I'm making. The golden rule for delayed operation. Again,
Okay.
first 3 days are okay. You can do everything, anything you want. First 3 days after surgery, after the injury. But once you go beyond 3 days, okay, it's a general rule, but if you think the tissues are good, you may extend for 1 or 2 days more. But once you go beyond 10, 12 days, stitches are not going to hold. Tissues are friable. Whatever repair you do falls apart. So the best thing is to wait it out for 6 to 8 weeks.
Okay, sir.
That is the golden rule. The only time you have to intervene, bite the bullet and do something definitive before the 6 to 8 weeks is when the patient is ill. When the
Okay,
patient
sir.
is septic, you find that you cannot control the sepsis with antibiotics with the proper drainage. Otherwise, repair depending on the injury within the first 3 days of injury. Beyond
Okay,
3
sir.
days,
Yes,
wait for 6 to 8 weeks. And in that period, your only job is to control the leak, make it a controlled external biliary fistula. if necessary, even with laparoscopy. Okay.
How do we do that, sir? How do we make it controlled?
Put more drains in.
Then, okay,
And
sir.
if you have a big gaping hole in the CBD, okay, you put a T-tube. That will control it
Yes, sir.
perfectly.
Hmm.
Then
Yes.
put a big, nice drains under the liver. Control that leak and see to it that he's coming out of sepsis. Because definitive operations on the bile duct, on a damaged bile duct, in the period between day 4, 5 to 6 weeks is fraught with failure. Okay, so that is something that you have to understand. So if you look
Yes.
at it, whatever you do depends, of course, on the level and the degree of leak, the time elapsed from the index lab quali, associated injuries, expertise available, and expert center referral is a must. So if your center cannot do it, send it to somebody who can do it. That's a very, very important thing. And in that point nicely made by Nikita, all you have to do is put a drain in and make sure that you have a controlled biliary fistula. Supportive care is very important. Okay. ICU, nutritional support. High-end cephalosporins are the best because they have the best penetration into the bile. Okay, so high-end cephalosporins, you can also use piperacillin, tazobactam, and meropenem, but my first choice is 4th generation cephalosporins. Now, if you have a small leak, we'll go step by step. I'm now getting into the different scenarios that you face, and we have basically discussed the basic principles involved in this. Okay, if there's a biliary peritonitis, generalized peritonitis, do a laparoscopy and do an abdominal lavage. And if there is no biliary peritonitis, and when you do this, abdominal lavage and drainage of the subhepatic space. If you do not have biliary drainage, but a bilioma, biliary peritonitis, but a bilioma in the right upper quadrant, ultrasound guided drainage. And as Sanya rightly put it, if you get enough control on the drainage itself, patient is getting better, you can wait. You can even avoid the ERCP. Otherwise, if the patient is not getting better, get an additional ERCP and a stent put in. If that doesn't work, do a laparoscopy or a laparotomy. And primary repair, look at the heading, less than 72 hours. Okay, you can do a primary repair. And if there is already an ERCP stent, you don't have to do anything more. The stent will protect your repair. Otherwise, you have to put a T-tube and then do a primary repair. Okay, that is if it is within the first 3 days. Now, if it is a large leak, and complete transaction of CBD, and there's nothing you can do about it, always then within the initial period, inexperienced hands, inexperienced centers, you can do a RUA hepaticojejunostomy. Okay, that's completely acceptable in the early phase. Also remember that if there is not a transaction but a clipping, then it is important that the biliary tree becomes a bit dilated for you to get a successful hepaticojejunostomy. If you have a 3-4 millimeter CBD or a CHD, you can do a hepaticojejunostomy, but it is more prone to stricture. And so you want to have a good 8-10 millimeter CHD or CBD if you can. For that, you can still wait. Even if there is clumping, there may be some jaundice. And what happens that makes you intervene earlier is cholangitis. You cover them with an antibiotic and wait for the CBD to expand when there is I'm talking about clipping, not a leakage. Remember, the previous slide showed leakage. Here I'm talking about clipping. So there is no free biliary leakage into the peritoneal cavity, but there is complete clipping of the CHD or the CBD. So it's worth waiting to get a slight dilatation of the proximal biliary tree so that you reduce the incidence of stricture of your hepaticojejunostomy. You have to intervene earlier if the patient gets cholangitis. Please remember, cholangitis is a fatal condition. It's a really, really dangerous condition. Never take it lightly. So if the patient is doing well, maybe some jaundice, but no fever, no signs of sepsis, white cell count is normal, you can continue even with a clipped CBD, but not otherwise. If the patient is getting unwell, intervene, drain this biliary tree well. That's the only solution for cholangitis, and the patient will live to face another day. If stricture occurs, so be it. We can deal with it in many ways afterwards. Okay, sometimes minimally invasive ways. A stricture of hepaticojejunostomy does not necessarily need re-exploration these days. Okay, so we'll come to that again as we go along. Is this okay, or have I confused you?
Sir, role of PTBD if patient is having cholangitis, we can't do so?
See, you can, but it beats the purpose. Why are you waiting with the clipped CBD? You want the biliary tree to dilate. Okay.
Oh.
And if you drain it with a PTBD,
Yes, sir, it doesn't.
it won't dilate. So you might as well,
Yes.
instead of doing a PTBD, you might as well go and do the surgery with the existing diameter of your CHD or CBD.
Yes, sir. Yes.
Okay. Yeah.
Yes.
Yeah. So if it's more than 72 hours, if it's a small leak, percutaneous drainage and stenting will help. Again, as I said, if something is required, 6 to 8 weeks is optimal. But anything that goes wrong and you feel that patient is not well enough, 3 weeks is something where you can go in. But this period between 3 days and 3 weeks is dangerous. And unless your hands are completely tied, with the patient deteriorating in spite of your ERCP and stent and drainage and all that, only then you have to do something definitive on the biliary tree, accepting that the failure rates are higher. But otherwise, the best thing is to wait 6 to 8 weeks. I'm repeating it many times because that is the message I would like all of you to understand. Okay. If it's a large leak, for example, you may get away with a percutaneous drainage stenting. But as I said, if you don't get away with it, you have to do an adequate drainage. Don't attempt hepaticojejunostomy at that time. Okay. Even if it's an open operation, get an adequate drainage, couple of drains under the liver, give a good washout, and almost certainly you will be able to get good drainage. You won't end up with a free leak of the bile. And remember, in all these situations, when you have a large controlled biliary fistula also, patient may not be septic, but the patient will have serious issues with fluid and electrolyte loss, as Ganesh mentioned. So you must always keep an eye on the patient's electrolytes, patient's nutritional status, and patient's electrolyte, fluid status. This is something you must always bear in mind, not just surgery. Supportive care is important because these patients are ill. Okay. And if you get away with a good drainage, 6 to 8 weeks you wait, then your option is to do a hepaticojejunostomy. As I said, in very, very a small number of cases, you may get away with a choledoc or duodenostomy. So we now come to the important science, science behind some aspects of how you do a hepaticojejunostomy. And a lot of it depends on our understanding of the blood supply to the bile duct. Okay, Nikita, what's your understanding of the blood supply?
Sir, it is a 3 o'clock and 9 o'clock position, sir. The artery branches which take to
Right?
the bile duct. So if the injury occurs at this point, it is very difficult for the anastomosis to heal well.
Okay.
And we have to technically we shouldn't be using the cautery in these positions or clipping in these directions,
All right.
sir.
So even you have to cut or trim or whatever on the bile duct, do it in the anterior wall, not in the
Yes.
side walls. Correct.
Right. Yes.
Anything else? There is one other important point. So what feeds these blood vessels? It's at 9 and 3 o'clock position. What are the arteries that feed these arteries to the bile duct?
Cystic and hepatic arteries only, sir,
At
from
the
branches
top,
of
yeah.
hepatic.
And below?
Gastroduodenal arteries.
Correct.
Yes.
Next important question. What is the proportion if you look at the bile duct as a whole, what is the proportion of contribution of these arteries? That's an unfair question to ask to a third-year-old, even a registrar. But this is an interesting and important point. Please note that the large majority of blood comes from below, 60%. Okay? And 40% comes from the top. What is its surgical implication?
So in case of repair, we
See,
need to
you have clipped off the bile duct here. Okay? You have clipped off the bile duct here. So what is your implication? So you want, you've clipped off the bile duct, you're taking a loop of jejunum to somewhere to the common hepatic duct there, right?
yes, sir.
So what is it that you want to note in the common hepatic duct? Now, if you clipped off the lower end, which means even the blood supply, the major portion of the blood supply, which comes from below, from the inferior part, is cut off. So the bile duct or the CHD is surviving from the 40% of blood that comes from the top. That's not clipped off. All right. So the longer this segment is, the higher are the chances of a leak. Higher are the chances of an ischemia of the lower end of this CHD or CBD remnant. So you want to choose a point which is not too far away from the confluence. At the same time, if it's very near the confluence, technically putting your sutures there will be difficult. You won't be able to reach to put this to. So you put the sutures. So you have to find a point, a via media, a compromise where you are doing your anastomosis as high as possible, as near the hilum as possible, without making it too difficult for yourself technically to place the sutures. Okay, that is the lesson that I want. So even if you have a very long length of CBD here, where it's very easy to do the anastomosis at this level, try not to do it. Go a little proximally so that you do not compromise the blood supply to the CBD or CHD remnant. You got that?
Yes, sir.
Questions,
Yes, sir.
comments? Okay, no questions, no comments, I'll progress. Now, this is, I think, my last or the last but first slide. Roamai is ideal. Okay. So what you do is you have to mobilize the jejunum maybe 10 centimeters beyond the DJ flexure. And you can usually dividing the first arcade is enough. But sometimes even the second arcade, if you transjuvenate it, you will see 4 arcades in jejunum normally, 3 arcades in the distal bowel. So the first 2 arcades can be divided, but if you can get enough length of the jejunum with the division of the first arcade, that is the best. Okay. And then biliary limb, which is what is connected to the bile duct. This is the biliary limb that you see. It says 60 centimeters in the diagram, but 40 centimeters is what some others say. I usually take 40 centimeters. Okay, that is important. From the DJ flexure, it's 10 centimeter away. And so it's important that you have at least 40 centimeters of bowel from the common bile duct or hepatic duct to your end to side jejunogejunostomy here. Okay, so what is your understanding of this so-called access loop? Praveen.
Sir, I didn't get the questions.
I've shown a picture there called the access loop. So that gives you a big hint about what it is. So I'm trying to see if you know what an access loop is, how it is fashioned, and why it is fashioned.
For further imaging, sir, if required to
No, let
access.
Praveen
Sorry,
say.
sir, sorry.
Yeah, let Praveen say, yeah.
Yes, sir.
I was talking at length while I was answering Sanya about a complication of hepaticojejunostomy. What was it?
Sir,
Stricture. I kept on saying
yes,
that.
sir. Yes, sir.
Yes,
Because
A
of
good size
gas.
for the CBD or CHD.
Yes, sir.
Otherwise, it will undergo stricture. So
Yes.
I'm giving you a hint, Praveen. So what would an access loop do? You can see the picture, right? What do you see in the picture?
Sir, it used for dilatation, sir.
Yeah, but what do you see in the picture? Just describe what you see in the picture. It even tells you what it is. Subcutaneous access loop, it says.
One of the loop is kept in the
Not
subcutaneous
one of the
veins.
loop. There's only one. There's
one
no
end
loop
of the
there.
loop.
Sorry, the end. The
One
end.
end, one end. Yes, sir.
One end of that mobilized, bubble. What's happening to it? What have they done for that? They have stitched it up and brought it under the skin there and then anchored
Yes,
it
sir.
there. Okay? Have you seen
Yes,
that?
sir. Yes, sir. Yes.
Yeah, it is just brought under the, it's not like a stoma. They don't leave it, not some people leave it open, the minority of people, majority of surgeons. I've done it about 3 or 4 times. We always stitch it up and leave it under the skin. So in case you have a problem with the hepaticojejunostomy, then you have an access to it through either radiology or through even endoscopy. You can put a choledocoscope, a small scope, through here and see what's happening to your anastomosis. But that is called the access loop. Okay, I seldom do it. I've done many hepaticojejunostomies, but I put the access loop very few times because usually the situation is that I have a fair-sized anastomosis and I do not bother too much about possibility of stricture. Even if it is there, you have percutaneous transhepatic methods, radiological measures, where you can dilate the stricture and put a stent or whatever. And so access loop has become less common as percutaneous radiological test techniques have improved. Okay, and the anastomosis itself has to be done diligently. One of the common causes for a stricture is a leak. If you have bile leak at that point, then you end up with inflammation, and the inflammation causes fibrosis, and you end up with a stricture, maybe 2, 3, 4 months later. So avoiding a leak is very important. So what you do is place, if the anastomosis is high up, place the sutures first and then parachute it. I hope you understand when I say parachuting. Place all the sutures first nicely under vision. It is serosubmucosal on the bowel side and full thickness on the bile duct size, and parachute it onto it so that there is no leak at that point. We use something like a PDS, delayed absorbable sutures, and make sure that even though it's an absorbable suture, you do not leave any knots on the inside. Knots take longer to dissolve. And so if you have, as you know, this last 3 months, PDS lasts 3 months. And if you have a situation where you have a knot lying inside the CBD, okay, for 4 or 5 months, then you end up with concretions and stone formation even there. So make sure that you don't leave any knots inside, and all the knots must be outside. And in spite of a very good technically well-performed anastomosis, always drain that area so that if there is a small leak, that doesn't cause further damage, further infection and anastomosis. All right, I think that's all I have to say, and I would welcome any questions or comments on this.
So you had put a suction drain.
Yeah.
Do we require to have a suction, sir, or regular drain? You mean?
I always, many people use an ADK and leave it at that. I put a smaller but suction drain, but either of them can be used.
Okay, sir.
Yeah. It must be a closed drainage, that much I know. That's for sure. So you put an ADK and just gravity drainage, or put a suction, size 16 is what I normally use, suction drainage. You can put a suction on the ADK also, on a 24 ADK also. That'll also keep it well. It's good to suck the secretions out, I think.
Sir, how did you manage your that first injury, sir, the
Very
CBD?
first injury, I repaired it over a T-tube. My very first injury. It was a small, I think it was a cautery damage to the right side of the CHD. And so I opened the patient, of course, very early laparoscopy days for me. Today, I might even attempt it laparoscopically, but at that time, I was inexperienced laparoscopically. And so I opened it, put a T-tube and patient did well. Yeah.
Okay. Sir, and also when we put a T tube, after 14 days, we do a T tube cholangiography.
Yeah.
And before we remove the T tube, like generally we do that part. Could you explain a
All
little
right.
bit?
I usually do it 7 or 8 days. I don't even leave it for 14 days. Okay. 7 to 8 days is good enough for you to know that there's a proper drainage. The important thing is when you are stitching this CBD, okay, all the sutures must be superior to the horizontal limb. Do you
Hmm.
understand?
Yes, sir.
You
Yes.
have a hole in the CBD, you have put the T tube. You must put the T tube, and I always cut a gutter on the other side. It's called a gutter, so that there is more flexibility of the limb of the T tube that is sitting inside the CBD. So you move it up and down. I'm giving you just some technical hints. Move it up and down freely. And when you suture the polydichotomy, make sure that the horizontal limb is at the lower end of the,
Okay.
not at the upper end.
Hmm.
Because when you tug, the pressure is on the lower end, and there should be an intact CBD there. Okay.
Okay.
And your weaker area, which is your choledochotomy sutures, must be at the upper end. So
Hmm.
when you pull out the CBD, that you don't have any problems. And so you pull it out only after you make sure with the T-tube cholangiogram that it is normal. And it can be done 7 to 10 days. It need not be up to 14 days. And when
Oh.
you pull it out, if you have any difficulty in pulling it out, don't yank too hard. Just leave it. Pull it out
Hmm.
as much easily as much as you can and strap it there. And that will give a gentle traction on the CBD, and almost always 2-3 days later it will come off. So
Okay.
those are the little practical hints I would like to give you. Yeah.
Yes.
Sir, once this is a doubt I had many times and people clarified. Once you remove the T tube, the area which is of the biliary tree which is open through which T tube was inserted,
Mhm.
bile leak won't happen through that area, sir.
Very, very seldom it gives you trouble, because the thing that you must be sure of is that there is no distal blockage. You
Yes, sir.
will have problem with persistent leak from the T-tube hole after its removal only if you have distal blockage or even spasm. So when you do a
So
T-tube cholangiogram,
yes,
if
sir.
you have a free flow of the dye into the duodenum, you will have no problems. But
Yes,
if
sir.
you
But
find that,
what's the mechanism behind that, sir? Even though we have an opening there, why
yeah,
are we not having
this
bile
is
leak
a
there?
this is a surgical principle which we were teaching people in the gastrojejunostomy days. Now, it's been shown many times, and it's true, it's a surgical truism, that when a normal passage is patent, okay, fluids never take a surgically created artificial passage. That's true of all surgical plumbing operations. All
Okay,
right.
sir.
So the classic example was, if you do a gastrojejunostomy in a patient without a pyloric stenosis,
Yes, sir.
okay, many times the food that you give or the barium that you give goes through the pylorus
Hello.
rather than the GJ.
Yes, sir.
Yeah.
Sir, but will this mechanism not hold in case there is a CBD injury that we have done?
No,
Why will the
it
bile
doesn't
not
matter.
flow in
As
the?
long, no, no, you see, as long as you have stitched up healthy tissue, okay, even if there's a damage, you have stitched up healthy tissue. So it will
No,
behave
sir.
like a
I,
normalcy.
I'm asking in general, after the laparoscopic cholecystectomy, suppose we have
Yeah.
made a small rent, like what rent we make for a T-tube. That
Yeah.
rent has happened in the CBD after a laparoscopic cholecystectomy. Why doesn't the bile then flow in the normal channel, and why do we have a leak there but no leak after a T-tube removal, sir?
Good question. It is just that if you wait, you see, there is always an initial leak. Okay. And all the
In
problem occurs with that leak. That
Yes, sir.
normal, no, a hole which is there, which is made by the surgeon, will have a leak.
Yes,
And
sir.
the other important thing is, you do not know the status of the sphincter of Oddi at that time.
Yes, sir.
That may be in spasm. Okay.
Okay, sir.
And
Okay.
if that happens, there will be a leak. And once the leak occurs, It's a self-perpetuating phenomenon. The infection makes the patient's condition worse. The inflammation prevents the CBD from healing. The inflammation and the infection there can prevent the CBD from healing.
Yes, sir. Then same thing can we expect after a T-tubramol, sir?
No, because you do not
Infection and
expect, you've proven that there isn't any sphincter
block.
body block.
Yes,
There's no
sir. Yes,
blockage, there's no
Mm.
stone, there's no stricture, there is no spasm, and so
Yes.
it should go down the way.
Yes, sir.
And also remember,
Understood.
the CBD hole that you have after a T-tube is relatively small.
Smaller.
The
Yes.
dents that you have after your damage will be bigger.
Okay, sir. Yes.
Okay? If you have no other students, you have any questions, doubts?
Sir,
No,
what
sir.
about tube?
No. Okay,
Tube
Niranjan,
cholecystostomy,
closing
sir?
comments and then we'll close this session.
Hello, sir.
Yeah, I've gone on a long, I didn't look at the clock here. I should have looked at the clock. I've done it for an hour and a half. I normally don't do that. Yeah. Go on. Niranjan, closing comments and sorry, Praveen, you had some question?
Sir, what about tube cholecystostomy, sir, as a part of bailout procedure?
Cholecystostomy. Yeah, you can do it, but my concern there is always the possibility of empyema of the gallbladder. Okay, that's the limitation of cholecystostomy. Okay, so you need to have something definitive fairly soon afterwards. And so I think you can do it if you if you have no help, you're not confident about subtotal, you don't want to convert, you can do a tube cholecystostomy, but it will be less effective than a subtotal cholecystectomy. And I do
Okay, sir.
believe that most of us will be able to do a subtotal fairly safely. Yeah.
Okay, sir.
All right, Niranjan, your closing comments, please. Are you still there? Yeah, he's there, but he may not be there, kind of a thing. Yeah. Okay, if there are no more questions, thank you for your patient listening, and I will close the session. Okay. Good night.
Thank you, sir.
Thank
Thank
you
you.
very
sir.
much. Thank you.
Good night, sir.
Good night.